So good afternoon, everyone, online and on site. Welcome to the Spring Seasonal Race Forum. We're very happy to welcome you. We will start with some closing remarks for our course. Lorenzo.
Yeah, good afternoon, everyone. Thank you for being here. So, closing remarks. It was another good session, another great course. Thank you, everyone. It was another, as you can see, broad and international gathering from people from all around the world. 55 participants and experts from 20 different countries. Always good to chat with everyone and share the experience from all around the globe. Our deepest thanks, as always, to Valérie and all the team from the IRCAD and as well from the AV team. They do an exceptional work, as always.
And from the lab, too.
And from the lab, of course.
Don't have our pictures.
And, of course, a big thanks to the faculty. No course would be possible without you, so thank you very much for your dedication and your experience. And of course, thank you to the participants, okay, because no course without you any. Okay, so thank you.
I would like just to add that the participants were really, really, really great for this course. What do you think, Lorenzo?
Yeah, for once, yes.
For once. Thank you for your commitment. You did a great job.
Yeah, very nice session. Thank you, everyone. And I give back the floor to Alam for the rest of the...
Thank you, Lorenzo. So this was the basic course for some of you, the advanced, but we organize 3 courses a year, 3 courses, 3 level of courses, the basic, the advanced, and the master. So the history doesn't stop now, sorry. The journey continues with us, with IRCAD and IRCAD-IWC. So we have, during the year, many projects for online continuous education. You can follow us on the Instagram, the LinkedIn, on the website of IWC, International Race Center, or IRCAD-IWC. You will find all the information. We have some webinars that are very, very interesting webinars. We organize them with Lucian, Gustavo Gomez, Shihab. We have also Alfonso Prada here. We have 2 webinars a month, clinical case symposium, what we will have this afternoon, but we do it all the year. And we have also a race journal club. Alfonso, we organize the next journal club next Thursday. So here are our clinical case symposium, the journal club, and also the seasonal race forum. All the information are on the Instagram and LinkedIn if you don't want to go to the website. So we also have other projects, especially the race-based camp with WebSurge and IRCAD. Everything is free, so we invite you to have all the information in the website and to register. It is for free. The race-based camp is a huge project. You have the lectures about all the topics. We try to update everything all the time. It is free. You have 7 steps. And at the end, you can pass some MCQs and have a certificate with European credits. It's very important. And we also have the e-book. All the faculties have tried to add in the e-book the techniques, so it is free. You can upload the e-book for free. And we try also to update with new techniques this e-book. So what's new in 2026? We just wanted to tell you that we are now launching the first researchoscopy board diploma. And the first examination will be here in Strasbourg next November. That is a big project of 2026. You have here the QR code if you want to take a picture, and you can have all the information on this email address. So for the board, you just need to have 2 courses to have done a fellowship and also to have succeeded in a race-based camp. And that is the end. IRCAD-IWC expansion. We launched the first course in India last October, and we will launch our course in the US next October in Charlotte. That's it. Many thanks once again to the partners, the IRCAD team, WebSurge, and now enjoy Seasonal Race Forum.
Yeah.
Last word. Thank you.
Thank you very much.
Thank you, everyone.
So, I'm very happy to be here with my friend Shiab Taleb, and we will start
me
this
too.
seasonal risk forum with the great Eva Bauer. Eva is one of the most famous wrist arthroscopists. Yes, yes.
Not so much.
She taught us so much, and now she will continue to teach us about the first CMC arthroscopy and the treatment options.
Thank you. Okay, so some of you have seen already some pictures because I had a lecture also on CMC once, so I tried to not put the same one, but you will recognize some. Those have been in the advanced course. So what's about CMC1 arthroscopy? We have no conflict. If we look in the PubMed, just to have an idea, so we see that bars, they look very big, but finally it's 2 or 3 publications, the most one a year. It's around 30 over 20 years, or if you look for CMC, maybe it's 70, but a lot of them are also not only arthroscopy. This was the first publication from Menon in 1996 with an arthroscopic or partial trapeziectomy and the interposition with a tendon. And we can see here that it was laying down the arm. It was not in an upside position. 2.7 scope, 2.9 burr, but is quite big for a CMC1 joint, but for resection, I think it's okay. So how we stage it, Eden Littler, I think we know all of them. 1967, they presented resection suspension arthroplasty, and finally coming up 1973 with this radiological description, what probably most or all of us are using in their daily life. And then Badia coming up in 2007 with an arthroscopic classification. And here we see stage 1, 2, and 3 in a very busy slide with all proposals that he had at that time for how to manage and what you can do all in the arthroscopic procedures. If you look at this picture, it's also very busy, and it's maybe quite similar. And all the red ones, you can do arthroscopy. The open ones, there is in the white thing. So this is somebody who was looking if what we find in the radiological finding, is this the similar to the arthroscopic finding? And we know this from other joints that it's not always the same. And especially in this, because they was looking in CMC and STT, and at that point they saw that in the CMC they have some more severe cases, or it may be underestimated what we need to tell our patients. I think in STT maybe it's always sometimes the case, but it depends also that you have a very good X-ray, what is not that easy for CMC and the STT, because very often you have some coverage with other bones. So it's quite difficult to learn also this to your stuff. And here we can see that the CMC arthroscopic stages are higher than in the radiological ones. So then a guy from Germany, he was looking, is there geographical differences in CMC1 treatment? We know, for example, for the prosthesis that some years ago it has been also mostly used in the Francophone countries. Nowadays it changed a little bit, and the rest of Europe is doing same. So for arthroscopy, they found out that in a very low stage 1, the US surgeons prefer to do that in comparison to Europe. But if it's more advanced, then they do the same for the arthroscopy. And there was also looking for prosthesis and so on, but now we talk about arthroscopy. So what can we do in arthroscopy? What are the different things we can do? And we know that the mobility of the CMC joints anatomy relates directly to a predilection of degeneration, because the motion is in so much different ways, and it needs to be stable anyway. And if we have a 1 kilo pinch at the thumb, we have 13 kilo load at the base of the thumb. So there is really a lot of load on our thumb. And as he is alone, the thumb, he has no friends like the long fingers. He needs to do the work by himself. Also about arthroscopic management of thumb, carpal metacarpal joint arthritis. Clara Wong and P.C. Ho described this with all the different types what we can do. Clara rest in peace, please. You will be in memory to all of us. And it's very sad that she passed away some days ago. Systematic review. These are the 10 papers that we find. Wilkins, this is from the group about Hank Kurt, probably most of you know him. And that was looking what are the options. It was in 2018. There was a lot with an interposition, some with an implant, but it was only 10 papers at that moment. So it's not so much, but it's close to 10 years ago. But they find out that there is not so significant difference between the different arthroscopic techniques. But for sure, it's better than a non-operative treatment or non-treatment, because I think most of the patients have already a conservative treatment. But they don't report about incidence of secondary surgery, and unfortunately the case series are very low still now, because it's still not that common or that current procedure. And here's also a review from McKinley in 2021, and they have the feeling that it seems to be better if you do a partial trapeziectomy instead of just doing synovectomy and debridement. So it looks that being a little bit more effective, but all these papers are no high evidence at all. This was their survey, and there were some other papers included because it was 4 years later. But most of them have also partial trapeziectomy and or interposition, and only some of them with the shrinkage. But they also looked at the complications, what I find quite high overall. It's more than 10% over the different studies, and there are a lot of neuropathy and non-specific persistent pain, whatever it is, including CRPS. And I think we have a lot of small branches of the nerves running around the thumb area and the radial part, so maybe this could be a problem. And also the distraction or the key wire, maybe the irritation of some ends of the nerve could be a problem also. So now we go a little bit more in detail. What's about the portals? So we have the 1R and the 1U. What we can see, maybe I can show it like this, here and here. And here's the volar portal or the thenar portal, what personally I prefer, sorry. And this distal portal I never used. It was described from Slutsky. I think it's quite dangerous. Here's the radial artery directly. But if we do it a little bit more open, maybe we can use it. I never have used it until now. Thenar portal was described directly with with arthroscopic hemitrapeziectomy in 23, and they think that it facilitates the arthroscopic triangulation, what for sure is right. And I really propose to you, those that are doing CMC arthroscopy, use the thenar portal, because it makes life so much easier instead of using just a 1R and a 1U portal, because otherwise you're more or less parallel, and special the dorsal part is very difficult to treat at that point. Comparison with open procedures, there are some studies about that, and but here we have only 11 patients with an arthroscopic procedure and 18 LRTI. And if we look at the DASH score, I think it's quite horrible, 55 for the arthroscopic group. And here we see it once again. And secondary surgery, 8 out of 11. So I think this is really a bad result for the arthroscopic procedure, but maybe 11 comparing with 80, so there are more used and more trained, and we know all that this is why we are here also, that we need to manage that also, that we get routine in our procedures. Total trapeziectomy, this is only the 1 or 2 papers I found about that. Most of them do partial, and I think for going for a total trapeziectomy, either you take a very big burr or it takes a long time. So I'm not sure if this is an indication what I would like to do. I think partial is okay. For total, probably I open it up and take it out. And now about thermal shrinking. We go a little bit more about the stages. This, for me personally, it's in early stages. The Taiwan group do thermal shrinkage and have 2 publications, and they have good results. We also see small numbers, like in my own also. And here they transfix it in the CMC directly. You can transfix also metacarpal 1 to 2, and they find good results and benefits of this arthroscopic intervention. And even long-term results, they had at least close to 4-year follow-up, what is not so bad. And here we can see that the scores and especially the pinch grip really increased a lot. If we look here, 36 pre and 93 it's % from the opposite side. So this is really a big value. So I'm also going to what I'm doing in daily life, arthroscopy, sternocleidomastomy, shrinkage in very early stages, stage 0 or 1. And at the beginning, I add an Wilson osteotomy as well. Painful instability, reduce pain, increase function, and maybe we can delay the osteoarthritis because if it's more stable, probably it helps the thumb to stay longer in good shape. This was early results, and we can see it's only 2 patients a year, so it's a rare condition. And we looked for the typical arthroscopic approach like we have here. This is a 1R and a 1U portal, not a CEDAR portal, what I have done in the beginning also. If we look in the joint, it's a healthy joint. It's a little bit of synovitis, but there is no cartilage damage. And when you go with your radio frequency, be very careful with the heat, and you really need to make running water that you don't heat up and cook the cartilage. Otherwise, you make a problem for your patient and you didn't help him. 6 weeks post-op, we need a splint or orthesis that the scar formation can go on, and that it's removable for washing the hands, but not for walking around or make sports or whatever without a splint, because the scar is what we need, what it helps us. The corrective osteotomy we can do at the same time. We find out in our very small series that there was no better result. This is how to test the instability. Here you can see it in the clinical way, and this is quite stable, but you also can look on objective pictures with an X-ray, with a stress view, where you put the 2 first rows together and you calculate the subluxation, and there we find no difference. So if we have no difference, we decided that now we only do a corrective osteotomy in cases of early osteoarthritis. And the scores was quite satisfactory. The people was happy, DASH was okay, everything good results. And I think it's still a good indication, but it's quite young, female mostly, and it's really for the instability. And here we can see that. What is interesting, Ishibashi 25, he put a scope prior to the corrective osteotomy, and once he removed the plate, he looked again. And he suggests that articular cartilage repair may occur following osteotomy. This would mean that there would happen a regeneration. I'm not sure about that, but at least it cannot advance. But because you take out the osteoarthritic part of the bone outside of the load. But maybe it can regenerate, I don't know. So about regeneration, what can you do? You can fat grafting or PRP grafting. Most of that is done without arthroscopy, but there are some they are doing with arthroscopy, like in this paper from Deptula in 24. And here we have the situation. They also do it in a office-based version with a nanoscope, but what you can do for sure. And you put then he put fat and PRP, and they had quite good results and estimated that there is a regenerative potential of this treatment. Different papers are done about the fat transplantation, good reduction of pain, no clear distinction of stages, only 2 comparative studies, so the evidence is still very, very small or not so much existing. So the comparative study, but this was versus open resection arthroplasty, 12 months, autologous fax injection seems to have advantages, shorter time until resolution of symptoms, shorter operating time for sure if you just put the fat graft and don't do an open resection arthroplasty. There are a lot of other indications. Those who are plastics of you, they know that you can treat a burn scar or even scar after radiation, for example, for breast cancer, what works very well, and also in revision nerve decompression, the fat helps us a lot. And this is one publication that said, okay, only one PRP injection doesn't help in comparing to saline, but I think it's quite interesting also. So some of the orthopedic surgeons, they put it also in the other joints. They do 2 or 3 or 4 times. Not sure. There's also a lot of money behind what is the real effect. I think we need to keep in mind this also. We have used it in 13 to 15 with our first series, same approach for the wrist arthroscopy. Here we have a partial grade 4 cartilage lesion, and the rest of the joint, the cartilage is thinning but still intact. Removal of the free bodies, like you can do it, you can free it up with a needle. Pink needle is your friend in arthroscopy, and then you can take out these loose bodies. They can be quite big, and you can simultaneously harvest the fat. You can do it in regional and the fat in harvesting in local, and then sediment it, and then you can inject 1 or 2 milliliter. More is not possible in that joint, and more will not stay in the joint. I put nowadays just a splint for 2 weeks. Before we had also put some transfixation, what I don't do anymore. Pain reduced very well, but we see it's coming late, at least in our series, and the same for the quick dash. Strength is good, but also you see a better result after 1 or 2 years instead of just 6 months. Range of motion is the same, Kapanji is the same. People's satisfaction is also better a longer time. These are the more recent data, so it's only 50 patients and 10 patients reoperated after 3 to 24 months, 5 arthroscopic partial trapeziectomy for prosthesis. This is a just clinical case with shrinkage on the right side and on the left side fat transplantation. Well, there are quite good results, and they have a good function. This is 12 and 13 years post-op, what I think it's quite okay. We have still a narrowing of the joint space, but not really an advanced osteoarthritis. Some complications like trigger finger, but I think it's very common in all that we're doing all around the thumb. But still, after 10-year experience, I don't know exactly which patient is really good for this procedure, but you never burn bridges, so I think you can propose it to all patients. They don't want to have a resection, arthroplasty, or prosthesis at that moment. For the resection, there was description from Darin in 2006. Tyson Kopp, he was looking with interposition, without interposition. He didn't find an advantage for the interposition and increased costs, so he didn't do it at the second part of his publication. He's doing also like a sandwich, in the meantime, CMC and STT if it's necessary. Looks a little bit crazy, but it works well after his things. Jean-Baptiste, he's here with us, and they was looking for trapeziectomy and temporary cardiac distraction for the basal joint, and they had a very good improvement of pain, especially also they proposed it for young patients. I think it's quite nice because younger than 70, thank you for that. And here's the 2 different types of distraction. One is MC1 to MC2, and the other one is directly in the CMC1 joint. And interestingly, the nerve irritations was more in the MC1 to MC2 group. So maybe to fix directly the CMC1 joint could be the better solution if you want to transfix it. Here they have a lot of them doing with the ligament reconstruction, like this maneuver from 2012. Here is an APL distally based, and then going through the space and fix it with anchor in the base of the second metacarpal. But I think it's feasible, but it's not so easy to do it. They have good results, and here from the Turkish group 2019, They do a suspension arthroplasty with a button suspension product, also with good results. Those were looking about, do we need a suspension, an internal brace? Does it help or not? And they find out that there is not a necessity of an internal brace. So I think this is still an open question. This is an arthroscopy-assisted partial trapezectomy, but a wide approach later on for getting the tendon. So I'm not so sure for the advantage for that. They said, yes, you can really leave the capsula intact. What is true for sure, but I'm not sure if this is a really good thing. Just a few cases on my own. I do arthroscopic synectomy and partial trapezectomy. Sometimes a distally based APL, like a meniscus suture. You can just come from the palmar side, pull it inside, tie a knot here, and make a small skin incision. But most of the time, I just leave it like that. And here we have the partial resection. We need to be careful that we have everything removed what we need, and don't leave these picking out, because this patient will not be happy. So to be sure that you have a flat area, and you can interpose or not. You can interpose a palmaris longus also if you want to have it. I'd leave them moving directly post-op, and a removable splint just for comfort. No transfixation, but most of the publications was with a transfixation. And for sure, you can also use the scope for other resections, for example, after LRTI, going to the remaining ST joint, like we can see here. And here is the same. Here we have sticking out the bone, like here, and this is what is in coordinates to in the X-ray. It's very important to remove everything of that. And the distal scaphoid is going covered by the capitate, so it could be a problem. Here is the same. You will remove it. If it's very sclerotic, it's quite difficult because the scaphoid is just pushing down, and you try to remove it. And for sure, you can also do an arthroscopic assisted arthrodesis. I'm not at all in favor for the arthrodesis of the CMC1 joint, but I know that a lot of people in country are doing that. I prefer the motion in the thumb. One of my former chiefs said it's the most important joint in the human body is the CMC1 joint. You can do chondrografts, but we see this is also an open approach. And for sure, you can do an assistance of the Bennett fracture. Unfortunately, the video was deleted after the operation, but it helps sometimes. Revision options after arthroscopic treatments are open for everything. If you want to go for a prosthesis, leave the central bone stock intact that your cup is holding quite well, like we can see it here. And so stage-orientated therapy, patient-oriented therapy algorithm helps a lot, even if it looks quite busy. STT, if it's painful, in my personal experience, the STT is more a radiological problem and very rarely a clinical problem in CMC1, not in isolated STT osteoarthritis. And I welcome you for the first webinars. Most of you know that. We do it still. We started it since COVID, Mireille and me organizing that. And we would like to engage you to become a member that we can go on with the webinars. Here you can join that. Thank you very much for a wonderful time in Strasbourg again. Thank you.
We can start with the questions. Somebody has questions to Eva?
So if we don't have here, I have one in the chat. A guy is wondering from where you harvest your fat tissue and how much do you inject?
You really don't need a lot. The easiest way is from the lower abdomen, but you can go wherever you want. And we inject 20 milliliter of local anesthesia, and we harvest around about 10 cc overall. And if you have sedimented, maybe there's 4 milliliter fat remaining, and more than 2 will stay in the joint. So it doesn't make sense to overpress it.
Eva,
Yeah.
thank you for this beautiful lecture. We have seen that there is no consensus for what we should do. We do a partial trapeziectomy, and do you think you are treating mostly the CMC1 arthroscopically? Do you think that you are pushing the boundaries of the indication sometimes? That means, in which cases do you still do arthroplasty? Prosthesis.
I do a lot of prosthesis, and
what is the boundaries?
if the patient don't want to have a prosthesis because they said they're too young, they need to expect revision surgery for the prosthesis, or some patients don't want to have a foreign body and so on. So for them, I do a partial trapeziectomy without suspension. A lot put suspension or distraction. I don't do it.
You just do the trapeziectomy, no interposition.
Partial. Yeah.
No interposition. Yeah. And I have a second question for the denervation, because we know that in the early stages in young patients, we have this problem that we don't want to do trapeziectomy. We just want to do synovectomy, debridement in the CMC, and perform a denervation. Could you tell us a little more about the denervation? In which part of the CMC we should do the denervation? That is the first question. Should we do the denervation by the shrinkage? Because I had the question in the lab this morning. I personally don't use the shrinkage. I just do the debridement. Do you think the shrinkage is better for these cases of the indication in young patients? Please.
Yeah. So a denervation works quite well. In my experience, it works better in elderly people, also the wrist denervation. I use shrinkage only in the young cases for strengthen the ligaments. I have never used it, but maybe it helps. But I think the synovectomy also do a kind of denervation from inside. So I have never added a denervation. It's more the patients, they asking just for that, for the denervation. You can do that, but maybe we can add it also, but I never tried.
In other terms, when we do a simple synovectomy, for you, it is not a denervation. It's not an arthroscopic denervation.
No.
It's just what
no.
Yeah.
I believe that with the synovectomy we do a type of denervation, but the typical word denervation, yes, it's coming from outside and cutting the small ends of the nerves. They are going in the capsule, and I'm coming from inside with a denervation.
Okay, because if I'm not wrong, we have some anatomical study that shows that we have some receptors in the capsule, and if we do at this in this area some synovectomy.
Yeah.
Thank you, Eva.
And there was one publication got lost. I don't know. Yeah. They was looking for how much irritation of the superficial radial nerve happens in those that have osteoarthritis, and this was more than in the normal population. So I think there's sure a relation also especially to this nerve.
Thank you.
And I have just a general question. Maybe you will have an idea about this. Do you think that now in US we have the prosthesis? Maybe 2 or 3 months ago. Do you think that in near future we'll have a decrease of indication of trapezectomy or metaprezectomy with arthroscopy, because now the US got the prosthesis? Because a lot of papers coming from, instance, Tyson Cobb or Badia, and do you think that they will switch their mindset and try to decrease the indication because they will gain in confidence with using prosthesis? I guess, for instance, in UK it starts to have a big milestone regarding using prosthesis. Do you think it can happen? And so we can be influenced the other way. I mean, that say, okay.
I'm not so sure, because I think all these publications have very few numbers. And if you look on the LRTI, what is the concurrence still for the prosthesis in the most areas of the world? So probably the papers about the LRTI will diminish, but I'm not sure about arthroscopy, because this is always some years and then 15 or 20 or something patients like that. Nobody has a big series, so yeah.
Please look at the mic.
Do you think it's not sufficient, the injection of PRP in the joint, because you add arthroscopy? What do you add the arthroscopy to guide the injection, or for the synovectomy, or for?
No, not for guiding the injection. It's for the synovectomy, and especially you find loose bodies even if you don't see them in the X-ray. So it's more cartilage, and I think this is helpful. But this is not scientific. This is how I do it, and I don't know if the result is coming from the fat or is coming from the synovectomy or is coming from the combination. But the fat on top makes no donor site morbidity, and so I add it. I have no negative effect. We have no infection and nothing at all until now, and so I think it just can benefit from that, but I cannot prove it.
Okay, like it can be sufficient to inject or corticoid or PRP in the.
Yes, there has been studies, and the best results has been with the PRP fat combination. It's a group from Austria. They looked for these different types, but only injection.
And it is for initial stage, just for initial
it's different.
Stage. After
they use also different stages, 1 or 2, and sometimes 3 also.
3 too. Okay.
I have just one comment. We're talking about fat tissue, but it's a real world fat tissues. You have nanofat, you have microfat, you have a lot of different way to prepare your fat tissues. And they just found out that you have different way of having good results when you use fat tissues. And you have a team from Marseille, where is Jean-Baptiste, with Professor Magalon, who had described that the way you prepare it, it's the way that you get more good results or bad results. So it's not only taking fat tissue barely, roughly, and say, I put fat tissues.
But there's also, this is right, but you have also medical legal discussions and problems in different countries, because fat is not normally in the joint. So in some areas you are not allowed to prepare it differently. Otherwise it becomes a pharmaceutical product, and then you have to make a big list of everything. But I think.
Any other questions? So let's jump to a much punchy session. We have 3 clinical cases, and we will discuss about those interesting cases. And we start with Dr. Prada, who will prepare his laptop, and he will be struggling with,
just before
questions.
Just before starting, we have some polls, please, on site. Please answer the polls. Alfonso and the other speakers will put the polls, and online too. Please. Participate to the discussion.
So thank you so much for the opportunity, Lorenzo and Alan. I call this clinical case the biological vibe clinical case, which is a little bit of background in this patient. It's a male, 47 years old, right-handed. He suffered a distal radius fracture, at least as we can know, comminuted 10 years ago. In another place, they put a Vorer plate. So they removed the plate 6 years ago, and the patient had a loss in motion, but he was pain-free for the last 5 years. He's an engineer, so heavy-duty labor. He come to our clinic with 6-month pain in the wrist. His visual and analogical scale was 6 points in rest of pain and 8 during work. So a very important loss of motion. The range of motion was flexion 50 degrees and extension 60 degrees. And the supination, they have full supination and pronation is 70. I don't know why I didn't put it. And crepitus in dorsal flexion and radial deviation. We only had the CT scan of this patient. You can see here. This is the most important coronal views. And also, these are the sagittal views. So we have nothing more.
Great, thank you.
I don't know if it's enough.
So who will be the victim? In the front floor?
I think we have we start now the questions?
Yeah, I think
Can I put the questions now?
Yes, there is a first poll. There is a
dedicated victim after.
Now, first you have, for everyone, you have the poll here. What will be your first line of surgical option? And maybe you could give us the diagnosis, and you have the QR code on the sides. So Shihab thinks that the first row is the victim, but I will come to the last row of the amphitheater. Okay, can you give us your name and tell us what you think, please, about?
I'm Luca. I imagine we want to say arthrolysis from arthroscopic, but maybe I practice MRI, and I used to maybe do a partial fusion.
First, Luca, what do you think? Maybe Alfonso. Luca, what do you think about the diagnosis? What do you think about the diagnosis? Could you give us a diagnosis about?
I think it developed arthrosis with an intra-articular fracture of the radius, not good synthesis. And maybe the cartilage is used on the lunatum, but I don't remember, it's 6 months ago?
Yeah, so no, it was 10 years ago.
10 years ago, so I think there was a lack of
for
cartilage.
The last 6 years.
I think I do a partial wrist fusion.
Mm-hmm.
Okay, so we have partial wrist fusion for you. Okay, we have a comment from the US, Igor.
I was just going to say that I picked the first option, but I would actually do a denervation in real life.
So why did you pick the first one?
It seemed the closest. It wasn't an option.
He's in Europe. In US, you go back to
it's
denervation.
an arthroscopic course, right?
Yes, that's right. Yeah.
Yeah.
But I would actually, I
So
might do an
easy.
arthroscopy, but I would mainly to check the cartilage in different joints and see what would be my second operation, and then I would do a partial denervation at the
So
same
in the
time.
beginning, you will do an arthroscopy diagnostic.
Yeah.
Arthroscopy, and then if the cartilage is okay,
Well, based on the CT scan, I would do denervation regardless.
directly.
Yeah, but I would just use that to inform the second operation if the denervation fails or when it fails.
I have a question for our colleagues from America. In France, the denervation doesn't work for us. We don't understand why. It
Only
works.
in France.
Yes, I don't know in Spain, but in France it works for the German. In Germany it works, and in your hands in the US.
It
What
works.
are the overall outcome with the denervation?
It works moderately for me. So I tell patients you're going to be about 60% better. So the pain's not going to be completely gone, but it will feel less painful. You'll be able to do more with the same pain or have less pain with the same things. And then I currently do 3 incisions. Yeah.
Jean-Baptiste, you have a huge experience with denervation. Would you do here a denervation?
No, because he's totally pain-free.
Nowadays.
It's been painful.
Now.
Yeah.
So
now
now
it's
wrist denervation.
super painful. That's why he come to our clinic.
Okay.
For the last 6 months. So
I have
we
no understand that. So
Yeah.
I will perform wrist denervation in France. We have published recently in GHSU European volume publication concerning denervation in the intra-articular malunion, and its work.
Intra-articular malunion.
Marseille is not clearly
But
French.
Jean-Baptiste, can you give us your tricks? Because this morning I had the same discussion with Emmanuel Camus, and I agree with you. When you have full range of motion and only pain, and you have to save time because it will last 30 years before the guy keep on going with the wrist. I said to the patient, we'll have half. Half of the cases you will be decrease your pain, and the other half we have to think about another option. And Emmanuel Camus, who is a surgeon from north of France, told me I have almost the same way, and it's unpredictable for me. I do the same surgery as Fouget described, and I don't know which case will be the good one. So do you have some tricks regarding the series you published, or?
No.
my hands.
100% in my hand.
Yes, even in the north, why I was asking this question for the denervation in the north, I did my residency in the north, and my professor there had a huge series of denervation, raised denervation, and the outcome were awful. So either it's according to the surgeons, or anyway.
Okay, so we offer the patient.
We have another comment over there.
I was just wondering if anybody would go for wrist prosthesis.
We are no wrist arthroscopy.
Maybe we can have a look to the
After
polls.
arthroscopy.
Can we have
let's see the
the polls,
answers, yeah.
please? The results of the polls. Alfonso.
That's incredible. Yeah, I can see that. That's incredible because we offer the patient all these.
You can show us.
We offer the
please,
patient
results.
all these options, but he refuses to do the narration because it's. I think for us it's a little bit difficult to explain the patient that we are not gonna burn his nerves or his motion, and I think they don't understand well the procedure. So that's why most of the patients refuse to denervate his wrist. In our case, and he doesn't want partial fusion. So we offer at the end an arthroscopic arthrolysis to see the joint, and also if the joint is okay, an intraarticular osteotomy. So this is the video of the arthroscopy. So we are seeing from the 6R portal, and we are making the synovectomy and the arthrolysis from the MCR. So we can see that the damage in the cartilage in the dorsal area, which is more or less like 30% of the joint, and also a mirror injury in the lunate cartilage, as you can see there. And also a step off in the middle of the ridge of between scaphoid and lunate fossa, as you can see there from the MCR portal. MCR from the C4 portal. And we definitely made the arthrolysis, and we remove all the loose bodies in their joint. So this is what we gain in the motion. It's a range of motion in between dorsal flexion 70 and palmar flexion. It was 80 more or less. So these are the clinical photos at the end of the procedure, and the pain doesn't go out. So we offer the patient 3 PRP injections 6 weeks after the surgery, because he was very, very painful during the post-op. So he gained a better range of motion. It stops in between 60 degrees and 60 degrees, 70 degrees and 60 degrees, sorry. And after 6 months, he is still having pain, 5 during rest and 7 during work. So he's unable to work. So he wants a solution.
So we have now the second poll. The patient still have significant pain, we have seen. What would be your next step? You have the second poll and the QR code. I don't know, Lorenzo, if on the left side of the room.
Did he keep the range of motion?
No, the range of motion, the final range of motion at 6 months was dorsal flexion 60, palmar flexion 70.
So the main problem is the pain now.
The pain, yeah. So now he's better in range of motion, he's okay, but he's still having pain.
So if we sum up the case, arthritis globally, preserve step off, preserve range of motion. We started with only arthrolysis and arthroscopy and nothing else.
Nothing. Well, some kind of biological thing inside the joint.
Alfonso, can I make you a question? Why didn't you approach also the bone part while you did the arthrolysis? Because we have published with Riccardo Lucchetti and Bain that the arthrolysis of the soft tissue is only one part of the arthrolysis, but when you have a dorsal and a volar horn of the bone, you need to flat that also, and then you need to flat also the step-offs, like Paco del Piñal described. So I wanted to... Okay.
He's Spanish, you know, so...
I mean, we didn't do it because the patient don't want to do nothing inside the joint. So we planned an arthrolysis, and if the cartilage was okay, we planned an intraarticular osteotomy in the beginning. Okay. But the cartilage was done, so we only made the arthrolysis.
And so the lesions are only radiocarpal?
Only radiocarpal, yeah. I
Okay.
missed to say that. So the ligaments were okay in the midcarpal.
Yeah.
It was the end of the other video, but
We can add a poll. Are you surprised that it doesn't work?
no.
I'm sorry.
For sure not.
So I'm wondering what you would do. You have a question, Lorenzo?
I don't know.
Over
Would
there?
you would like to care to give your opinion
Yeah, I mean,
at this stage?
so far we've only done arthroscopy and arthrolysis, and we were talking about denervation, which is not on the poll, but that would be something that I would consider offering the patient now, before I do all of these other things, because I believe that you don't want to burn bridges, and it's also going to depend on what the patient wants. Like if you said, I just want to have one more surgery and then I want to be able to go back to work, it would be a different option, but usually I would counsel him now that I would go for a denervation.
So now you do a denervation?
Yeah, I mean, we haven't done one before, so it would be worth a try.
You would choose a denervation
Yeah.
now, or for Germany. I understand now it works. I'm wondering here, what would you do in one of the best units in the UK, in Manchester? Malek, what would you do in this kind of cases if you have to choose with that?
Well, we would have done a denervation. So definitely a denervation.
Denervation.
First. Yeah, so that would have been definitely, probably before we scoped them or anything, I think denervation first. He wants to work, I mean, reading between the lines, he's still working. You know, if you sell it, you're 2 weeks, you're less than 2 weeks, you're back at work, you know, splints, nothing. Most of our patients, they're quite happy. Once you explain to them that you're not cutting.
So I need to come to train in Manchester and in Marsilia for the denervation. So traditional options for everyone. Anyone has another?
Just a follow-up question for Malek.
Yes.
Would it be the same strategy if the patient was really stiff?
Again, it depends, because it depends what they want. If they're stiff, you're going to make them stiff with an RSL fusion. You're going to make them stiff with anything.
I know, that's why. But
so,
because one of the points of the denervation is to try to keep
some movement,
the pre-existing range of motion. But is there the same interest in doing a denervation if the patient is stiff and he can obtain the same range of motion with a partial fusion, for instance?
It would only be dependent on the patient's, I guess, current social state. Okay. You know, so if they want to work or if they want to go down that route.
Thank you, Chulki.
We have just sorry.
My personal idea. I think there's a reason why the partial fusion in the pole is so popular. Probably because it's not a perfect solution, but it's a predictable solution. So what I would do is put the patient in 6 weeks in a cast to give him the impression that he got the fusion. If he's used to, he's happy with it, then you're more in the way for the partial fusion. Otherwise not.
In this option is a partial fusion. You will put a cast in the patient because the patient will have a movement after a partial fusion.
Yeah, but I think it will be much reduced. You have like a distract radiocarpal joint. It will not make much difference. Yeah.
In articles, it's like in literature, it's like between 40 and 40.
I know,
40,
but
right?
in my hands, it's really an optimistic number.
So Alfonso, I'm a little worried for you because partial fusion is the majority of people.
But as I said, the patient don't want a partial fusion.
Yes, doesn't want. Okay, you can. I think.
I can continue.
Okay, you have.
Wait. No, the problem is when you fail in the first indication, it's complicated to explain the patient to make another procedure could not be the end.
Yes.
So that's why I choose in the second question partial.
Yeah, that's totally true. But the patient is still refusing.
But when we tell the patient we are going to do arthroscopy, I think it's okay because if you do an arthroscopic treatment, you don't burn the bridges for anything else. For minimal invasive,
I just had a question because, as I understand, he refuses kind of arthrodesis, but you can inform him about arthroplasty, prosthesis, if he wants to maintain movement of joints, so it will be an option for him.
Yeah, but our problem with arthroplasties is that he's a heavy worker and in the literature of prosthesis, the amount of heavy load they can do, it's 5 kilos. Yeah. So that's not gonna work.
That's right. This can be contraindication. But
yeah, for us nowadays it's a contraindication in heavy duty labor. So that's why we didn't plan that in the beginning. Okay, so the patient refused again to make partial fusion. So we offer him dermal allograft interposition, which is something in between what Paco del Piñal described is a resection arthroplasty plus interposition to maintain the movement and release the pain. So that's what we did. We again do another arthroscopy. We are working from 3-4 portal, so the view is in the 6R portal, so we are removing all the scar tissue from the surgery before. And now we are doing the resection to cut the step off in the joint, as Lucian suggested. So when we when we have our field properly prepared, we put the first anchor. So it's, as you can see, it's like a trapezoid image of defect in the cartilage. So we put 3 anchors in this case. So the first one is in the most ulnar area, here in this corner, and then we put another anchor in the dorsal area, which is here, and then at the end we put the third one and put the dermal allograft, which you can see here. We knot the three anchors to the allograft just to maintain that allograft inside the joint. It's like something very soft for the axial loading, so we don't want to be moving to get moved the allograft inside the joint. That's why we put these 3 anchors, and we have very good results doing it. So at the end, we put some kind of fibrin glue at the top to maintain the surface of the allograft, and that's what we did at the end. So this is the end of the procedure with the tissue, with the fibrin glue at the top. And we immobilize this patient for 4 weeks to maintain the dermal allograft inside the joint. And I have some literature to show you, but it's related also in the salvage procedures that we're gonna talk. We talked before. So denervation is for ROM when the patients have a good range of motion, but the results are unpredictable in the literature, not in Marseille and not in somewhere else, but in the literature it's unpredictable. The arthrolysis is indicated in non-anatomical misalignment or intrinsic joint pain, but the results are modest. And the radioscaphoid fusion, it's for the arthritis limited to the radiocarpal compartment. So in this journal for the team in Vienna, they explain how to do all these surgical procedures. So I find it's a very good article. And this is the article from Paco del Piñal, which show us how to do the resection arthroplasty by arthroscopy. So it's indicated in symptomatic radiocarpal pain with stiffness. So the main goal of this technique is to create a smooth fibrocartilaginous grading surface while preserving the remaining joint motion. So it is done by dry arthroscopy. So the first step is to do an extensive arthrolysis to regain working space and then remove all the step-offs inside the joint. So it is very important to preserve the volar rim, to protect the volar ligaments, not to create an instability in the radiocarpal joint, and they don't immobilize this after this surgery. So immediate range of motion, it's emphasized. But in our case, because of the dermal allograft, we put a cast for 4 weeks. So this is the only paper that I found in the literature about dermal allograft. It's a team from Los Angeles, and they use this dermal allograft in the proximal row carpectomy with some arthritis in the radiocarpal joint. So they find that with dermal allograft, the double layer of dermal allograft, this is the best performed because they restore the contact pressure to an intact and all position except the 10 degrees of radial deviation. So they think with dermal allograft they can increase the contact area versus the proximal row carpectomy alone. So to finish this clinical case, this is the exit pool to start fighting.
Yes, for the final decision, but we cannot finish without fighting a little. In most, in post-traumatic radiocarpal arthritis, no, you have convinced us, even in the UK and in the US, that there is not only the denervation. So now, just to finish, what is the factor that most influences your choice for the procedure? Patient age, remaining cartilage, radiocarpal alignment, functional demand, range of motion?
Well, I think the difficult thing is to choose only one because...
Yes, if we have to choose the main factor, maybe you can ask someone in the left of the room.
Switzerland is sometimes closer to France than Marseille.
Yes, Switzerland.
What would be your opinion on this?
I chose functional demand because that's a patient age alone doesn't say anything, or doesn't say what he wants to do still in life, but it is surely a combination of all. But if I have to choose only one, it's functional demand.
Yeah, if I will choose one, probably it's the functional demand.
The thing is that we don't exactly know how long this lasts, because this is something that I use a lot, this technique, and this is something that we use maybe, I don't know, 10 years or something. So I don't know if he had the chance to reoperate some early cases. I did some cases. The patch, the dermal graft is gone after a few weeks probably, but it's replaced by fibrosis and you know. So you have nonetheless to tell a patient that it might be a temporary option.
It's like a spacer, yes, that you use something for increasing the healing potential. At the opposite, when we do tendinous interposition, we had Matulin had to reoperate some patients, and when he puts the scope some years after, the tendons is still here and is still have a good quality. So.
So we start doing the tendon arthroplasty, which
interposition.
Interposition. But the thing is that our results were very bad. I don't know if it was because our technique or whatever, but
maybe you can combine Paris, Madrid.
Combine you can do.
I did some cases where I did tendon and
dermal allograft.
Yes.
Because you cover more.
Yeah.
Just to But the only thing, because I use a patch that is used for the shoulder cuff repair.
Yeah, this is the same patch.
And so you have to warn the patient, because in not so rarely it creates an inflammatory reaction in the first 2 or 3 weeks. Big one, sometimes a big one, and they are very painful. And at the beginning you don't exactly know why, and this is because of the patch. It creates a big flare-up reaction that can be treated with non-inflammatory drugs, but you have to warn the patient that they might be painful for 2 or 3 weeks. Yeah.
I totally agree with Lorenzo. I asked Pedro in the ASSH last year, because we are the team of the tendon interposition, and I started when I saw Pedro Delgado team a technique to use a dermal allograft, and I don't understand sometimes in my patients, and maybe it's my technique, in my patient we have an inflammatory reaction, a huge one in the 2 first weeks.
Yep.
Do you have this in your own experience?
Yep.
Okay.
We have 10 patients nowadays, and we find in 3 cases a big inflammatory reaction during 3 or 4 weeks after the surgery. Okay. That's why we put the 4 weeks cast, because we can, with this, in the first cases, the first 1 and 2 cases, we don't put nothing, just the anchors to remain the allograft inside the joint, but they start with a huge reaction, a big inflammatory reaction in the wrist. So that's why we decide to put the cast during 4 weeks.
Do you think it's mandatory to use anchors? Because I don't use anchors. I use only the glue.
Yeah.
Because you cast it, you know?
Yeah, Pedro now is working only with fibrin glue, but we're still doing the anchors.
To maintain the
Silvia and
patch.
me.
To maintain the patch inside intraoperatively. The patch is to maintain it inside. It is not, sometimes it's not auto-stable.
Yeah.
It's difficult and it moves. If it's not, even if you before putting the glue, and I'm afraid of migration, secondary migration.
Yeah.
Of
So
the patch.
one comment about that, because it's important. You have to fix it somehow, otherwise it moves.
That's what I think.
And so France, we don't have the money to buy the fibrin glue. So yeah.
The derma costs so much.
Exactly.
It's just for the glue.
And so, but putting anchors is sometimes difficult, technically. So what I do now is I fix some Vicryl or any kind of sutures, absorbable suture at 3 different points of the patch, and just exit the sutures at the skin and fix it with stair strips at the skin.
At the skin.
At the skin at 3 different points. So it's tensed by the fixation at the skin, and then at 15 days I cut the sutures at the skin, and that.
So, which kind of sutures do you use? It's
Vicryl or
Vicryl or something. Yeah, that's quite nice.
Next case, maybe.
Yes.
So
there's a question there.
What's your limit of cartilage damage to use the?
The size of the patch.
Yeah, no, the patch is super big because it's done for shoulder surgery. So. We don't have a limit, in fact, but because it's very rare to see the whole damage joint in the radiocarpal. But our cases are like between 30 and 40%, because the most common indication is the slack injuries, which has a big dorsal rim injuries that don't cross more than 30%, and also these radius fractures, so 50-50.
So thank you for the question. We have to go to the next cases. Ali, please, can you share with us your next case? And as you've seen, it's really, really demanding regarding the question. You will have to struggle with the panel.
Yeah, good afternoon, everybody. And my case is a 50-year-old female, a housewife, has a history of falling down from down the stairs 15 years ago, immobilization with a cast for 1 month. She came us with a right wrist pain for 5 years, and progressive worsening over the past few years. And the examination has then occasional radial sided swelling, limited range of motion, and she has pain at rest and exacerbated by activity. And the degrees of the range of motion, she has a 45 degree of flexion, 60 degree of extension, 8 degree of radial deviation, 20 degree of ulnar deviation, and 60 pounds grip strength. And the VAS score was 8, Q-59, and patient rated wrist evaluation pain score was 56, and function score was 41. And the X-rays of the patients is here. And we move to the poll 1. What's your diagnosis?
Thank you, Ali. Here is the first poll, and you can start to vote here. And if you can take comments, maybe.
Sorry, have you have a time to see the X-ray?
Yeah, can you move back to the
okay.
No.
I come back.
Yes, you can put the X-rays, and after we have on the sides we have the poll. Is there any French people that would like to give us a comment? Because French, they are not. Do you have any comment, my friends? I am just behind you. Yes. Can you tell us where you're from and what do you think about this? Can you just tell us, please? Put your. À gauche, le bouton.
I'm from Belgium, not from France.
No,
but, I think this is a snack wrist stage 1. There is a styloid and scaphoid arthritis.
Yes.
There is a debate between 1 and 2. No one agrees there. So.
Yeah. So
who voted for 2?
What did you vote? What is your name?
I voted for stage 1.
You voted stage 1, and do you need some more diagnostic tests to go further in the diagnosis here?
We could do an arthrosity.
Okay, so we have no one agrees with there is no consensus on the polls. Yes. Can we have the polls in the screen, please? In the main screen, the poll, the results of the poll. Okay. So.
Chulki, would you vote 1 or 2?
I vote 1, but on X-rays you can't really decide.
If there was an answer 1.5,
I hope it has 1.
Who would have voted 1.5?
So half and half. I think you can go on. Yes.
Okay. So what was the answer, Ali?
And the answer is it's the stage 1. Here is the. How can I move?
To move.
Could you move the video? Where?
So.
From?
Click on that.
Okay.
We can show it like this.
Okay. The CT scan of the patient.
So I just want to know if someone would choose the MRI instead of the CT scan here. No? Me, I would choose the MRI here. Do you have an MRI?
Yes,
Emily?
we chose both.
Ah, okay.
MRI.
In Turkey, as usual, they have
In
money
Turkey,
and they have
we are lucky
everything.
we can
Yes.
So fancy.
They don't choose. They do everything in Istanbul.
Okay.
So what did you see on the MRI?
I can move again. So
yes, we have a comment from Igor.
Just a question. Yes. What do you hope to get from MRI that will change your management?
Yes, for MRI, I think if you are asking me the question or anyone else, okay. Me for the MRI, I choose the MRI because I think it's one of the best exams to analyze the quality of the articular surface, especially in the mid-carpal joint, that could change my therapeutic option, and that would be the main reason, not for vascularity reason, because in this case the vascularization is not such an issue and a concern.
I just thought, this being an arthroscopy course, you'll put a scope in instead.
For me, the most important thing is the arthroscopy analysis, yes.
Yes, but in France we don't do diagnostic arthroscopies much.
Sometimes, very rarely, when we don't understand something.
It has to be therapeutic in the same times.
Yeah, we do the diagnostic and therapeutic. We put it in our, yes.
Otherwise you get fired by the social security system.
Ah.
Yeah.
So yes. So what about here is our second poll. What would be your preferred treatment strategy for this patient? Do we have any? Igor, you're just in front of me. Did you vote for this? Why? Can you tell us a little more?
Arthroscopic?
Yes, of course.
I hope. Yeah.
I mean, it's arthritic, so I think you have to get rid of that articulation, yeah.
Anyone else? I see most of the people choose the radial styloidectomy.
About Italy?
Yes, what
Italia.
would you?
Forza.
I'm not sure that only a radial styloidectomy could solve the problem, because she has a lot of pain and she has a limit of motion yet. So probably my first thinking was about a proximal row carpectomy to give her a definitive solution, and she can get well for several years, and she can gain gain movement not, but more or less she can move without pain, and in our hands proximal row carpectomy get very well. So probably was my first thinking.
Thank you. I think our experts are very discreet. You don't hear them so much. I see in Norway, we have our team from Norway. Could you please just share with us your comments about the case? Jan, please.
From what I see from the x-rays, I think there was a non-union of the scaphoid, and I think there was dissociation between the scaphoid and lunate, so maybe she has a scaphoid non-union as well as a ligament injury. So I think if you scope her, she will probably have more than just a slack or snack with stage 1. I think it's more than that. I would discuss with the patient, and whatever I see, I would probably suggest to go on with the. I will think there could be an proximal row capectomy.
So for Jan, it's proximal row capectomy, and Andre, it would be the same for you, I imagine, yes?
Yeah, I would agree. I think it's important for these patients to find a definite solution for the problem, and I expect the problem to be pain, so you need to get rid of the pain. And I think the other solutions will maybe reduce the pain for a short time, but I would do a salvage procedure. I would also do a radial stellectomy together with a proximal row capectomy or a partial arthrodesis or full corner fusion.
But is there someone who would like to try to salvage the scaphoid, to reconstruct, to graft it?
Maybe we can try a APSI, no?
Who said APSI? Okay.
Please stand up and say sorry.
Who said you said APSI, yes.
To everyone who tried it before.
No. What about the what about the arthritis? What do you think? It would be a spacer. Do you have any experience in that? Because it is a question. Why, if you can use an implant in the proximal.
I do full-time APSI with a styloidectomy, and the patient was good.
Yeah.
Young people too.
But you need to make sure that the arthritis is really on the radial compartment, and it is not. But it's an idea.
No, Alam, he's a liar. I know him.
Okay.
No, they didn't get well.
So
no.
maybe you can yes. Go. You can go on with the case. We see that most of the of us, majority is for radial styloidectomy and under arthroscopy, of course, and or proximal row capectomy, and 2 for interposition. Okay.
Yes, we choose to do an arthroscopy first before make a more extensive surgical approach. Oh, sorry. Here our scope is in the 3-4 portal. We start to see the ulnar carpal joint first. Check the cartilage and the TFCC. And cartilage looks like not bad of the lunate cartilage. And later we will check the TFCC. Yes, here TFCC also looks good, just a small central tear. Not so important. And the cartilage is good. So we turn to the scope to the radial side of the joint, and as you see there is a degenerative process there. The synovitis and degenerated cartilage, and we open our 1-2 portal and start debridement with the shaver. As you see this proximal pole on the right, and after the debridement we check the joint. As you see here, you will see more clearly the distal part of the scaphoid. There is a total cartilage loss in the distal part of the scaphoid, and also in the total cartilage loss in the radial styloid. So we start some resection from the distal scaphoid to widen the space. And then do our radial styloidectomy. And after we put an anchor to the styloid, as we continue with tendon interposition. And we use palmaris longus. We use a tendon stripper to take the palmaris longus and use palmaris longus as a tendon interposition for the interposition. We use sutures to carry the tendon through the joint from the 1-2 portal to the volar radial portal. We pass the tendon. You will see the outside weave later. Here we take the tendon from 1-2 portal to the volar radial portal, and then from the volar radial to the volar ulnar portal under the flexor tendons, and then from volar to the dorsal. We take the tendon from volar to the dorsal to the 6R portal. Then under the extensor tendons, we pass the tendon to the 3-4 portal, and then again into the joint from the 3-4 portal to the 1-2 portal. And we use this anchor sutures to fix it to the styloid, and then we make a tendon ball there, and later pull the tendon ball inside to the joint. And after the arthroscopic view of the tendon ball in the joint. So postoperative X-rays of the patient. CT, postoperative CT of the patient. And the 1-year follow-ups, the flexion and extension decreases a little bit, but radial deviation and ulnar deviation increases in the first year, and the grip strength also increases. But the significant difference is seen in the patient's pain. The WAS score, Q-dash, and patient-rated wrist evaluation scores are significantly decreased in the first year of postoperative period. So this technique is first defined with Dr. Ariani and Dr. Matulin. They used this tendon interposition in stage 2 slack wrists. They reported 14 patients with a mean follow-up 53 months, and their results that there's no statistically different in preoperative and postoperative flexion and extension arcs, but grip strength improved significantly after tendon interposition, and their patients' DASH scores and WAS scores also improves after the operation. And later, Bergamon et al. Modified this technique. They because in Matulin techniques you have to use the volar portals. It is technically difficult. So especially in the slack wrist, the cartilage loss is especially in the dorsal part of the radiocarpal joint. So they modify the technique. They do one loop interposition, and they report their results in 3 slack 1 wrist and 12 slack 2 wrist, and they found decrease in pain score from 7 to 1 and increase in grip strength as Matulin's paper. And I checked for the scaphoid non-unions, is there any tendon interposition, and I couldn't find so many papers in the literature. I found this one. They use in this paper, the authors remove the proximal pole and put it there a palmaris longus ball interposition, and they have 6 patients SNEC 1 and 1 patient SNEC 2, and they say they reported that even good subjective clinical results was observed. There was significant increase in SNEC stage at the follow-up in their patients. So in conclusion, arthroscopic radial styloidectomy and tendon interposition is an acceptable procedure for stage 1 neck wrist, and this procedure yields acceptable functional outcome and reduces pain, but it's technically demanding, needs experience in wrist arthroscopy, and has a longer duration of operation. And the last poll.
Thank you, Ali. So we have seen two ways to do interposition. Just a comment. What I like in your technique from the original technique, it is the ball on the radial compartment. I think you have the ball is important when you take inside the ball, which is not necessarily what we do in the. And I like the palmar portal to do the interposition, because I think we cover easily.
Yes,
so here is the last poll. It is for the debate. Is radial styloidectomy alone sufficient in SNAC stage 1? Yes. Only combined with interposition? No. Only in carefully selected patients. I would like to know who didn't. Our experts are very discreet. Eva, what do you think about this? Please help us a little.
I don't think that radial styloidectomy is sufficient alone. In this case, maybe in very early stages, I'm not, to be honest, I don't do so much radial styloidectomy, because I think it's more a point. You need to do something else in the future, and I think we really need to discuss with the patient also if they want to have a small treatment but more treatments, or maybe they want to have a final solution and a one-step shot. What is, for example, in the other case, a proximal row capectomy. So I think it depends a lot on the social situation, on the working situation, and so on. I think this is something what we need to keep in mind.
Thank you, Eva. We have a comment from Jan. Just it is a snack, and before it was a radiocarpal arthritis after trauma. I think the origin of the arthritis is the etiology is very important for the indication. Jan, please.
You didn't show us the arthroscopy of the central part. You didn't show us the SL ligament. You didn't show us anything for the metacarpal. I wanted to know if there is an SL instability. How was the status between the proximal pole of the scaphoid or not? Because I think this solution is like this joint looks to me. It's what you did is like peeing in the pants. It feels good for a little while, and then you're back, and she has to do something else. So, personally, I would not have suggested this for my patients.
But we need to keep in mind, Jan, that in some situation the patient refuses the salvage procedure. They refuse.
Yeah, actually, but he didn't say anything about this for this patient.
I'm going to tell you, to shorten the video, I didn't put that, but I explored the midcarpal and the ulnar part. I want to show some part of the ulnar side, and the middle part of the radiocarpal is the same. The cartilage is not so bad, it's good, and I didn't find any scapular instability in the midcarpal joint, and midcarpal joint is also not so bad, good in quality. That's why, why we choose this technique, because after this technique, we can maybe delay the other intensive, the more big surgeries, 5 years, 10 years, 15 years, we don't know, we can delay this. And also we have a chance of to do this in the later again. So, and the patient has housewives, the main complaint is the pain, so we have to solve the pain with minimal techniques. That's why I choose radial styloidectomy and tendon interposition, and for now it works because the pain decreased significantly after the first year. She had already restricted range of motion, so nowadays it's the restricted range of motion doesn't disturb her. The most important thing is the pain for her. That's why we start with this technique, and we will see how long it will survive for these patients. And after that, when she feels pain, the other options like proximal row carpectomy or partial wrist fusions can be done.
Okay, thank you, Ali. I think just we can take a last question.
But really quick one, because
yes.
we are 30 minutes for each cases, and Schulke
yes,
will
I
be
know,
frustrated.
But we are on time until now.
Just it's a question and a comment, but in the technique with the interpretation you talked about, but Margaret Ariani and Christophe Matoulin, it was described for a slack technique.
Slack, yes, it's slack.
And in the technique, they also treat the initial cause, which is stabilizing somehow the scapholinate, whether with a capsuloplasty or something. But here it's a snack. So you are letting evolving the non-union of the scaphoid.
Yes.
So that's why I was asking the question at the beginning. If you do a preserving technique like this one, which I like very much though, but is it not interesting to try to make the scaphoid more stable by grafting it, or I don't know, but because if you're letting the non-union evolve, I don't know.
Yeah, it can be option if I can think to graft if the patient is younger, and when I scope the joint, I saw the distal scaphoid with a total cartilage loss. If there would be a good cartilage and the patient is younger, yes, it can be a good option. I can do the radial stylectomy, and in the same time I can graft the scaphoid.
Okay, because the conclusion is like Eva said, radial stylectomy alone is not a treatment in itself. You need to treat the cause, but in some, because this was a big stage 1, you have a lesser stage 1. That
yes,
you can treat,
this is a big stage 1.
You can transform it into stage 0 by doing the radiostectomy and then graft it.
Yes.
So that's what.
That's why it's a late stage of stage 1.
Anyway, thank you very much.
It's going to stage 2.
Yes,
very nice case. Thank you very much.
It's an application, but it's very nice case. I think we need to move, but we have a very late.
Schulke, please.
Yeah, I was also thinking the same as Lorenzo. Why not stabilize the scaphoid by grafting it, and just do the styloidectomy as a plus, because it's the distal scaphoid that butts against the styloid. And just another option, maybe out of the box, my Belgian friend, Frederik Verstreken, he developed a PSI scaphoid prosthesis, which can maybe in this case also be an option.
Yes, and let's very quick comment, please.
A quick comment. There were some papers published last effort when there's scaphoid non-union and SNAC1 arthrosis, when the grafting and stabilizing the scaphoid shows the same results as other options, proximal capectomy or fusion. So just the option.
Many options. So next year, Ali, you will tell us how he's doing your patients.
I will call the patient again.
Thank you, Ali. Very nice case. Thank you.
So now we'll jump to another case with Schulke, who kindly will share with us a case from Tienen, Belgium.
Hello, thank you for the opportunity to present my case. This is the case. It's a 62-year-old male, retired with dorsal-radial pain for about 2 years with significant dysfunction and no history of trauma. The VAS score was 2 out of 10 in rest, and during loading 8 out of 10. Clinically, a positive Watson shift test with pain but also some clunking, versus the other side, also some clunking but no pain at all. He had first a conservative treatment, but it failed. So this is the guess poll.
Yes, for the
most likely diagnosis without having any supplementary exams.
Many people left, but. Okay. Do you want to give some comments? Yes. Do we have someone for some comments? Could you just give us your name? Where are you from, please, for the attendee?
My name is Paul, and I'm from Poland. Can we? Do you have maybe some diagnostic?
Yeah, we have some.
Just in this case, clinically.
Just for the fun, make a guess.
Yes, just make a guess. Pain, Watson plus. What did you?
Painful Watson, dorsal radial pain.
Yes.
Chronic.
Yeah.
Can you come back to the first? Please. Yes, you can see we have a Watson click.
Clear dysfunction.
Yes.
It's really having problems.
So.
Okay.
Yes.
Should be. S or B.
Scapholunate instability.
Yeah.
Okay, dynamic instability. Yeah. I think we can go on. Yes. Most of the patients, we have 9 people that voted for early slack risk because we don't have the X-rays.
So for these kind of pathologies, we ask for these incidences. This is a normal PA view in radial deviation, in clenched fist, and also clenched fist in ulnar deviation, and the butt view described by the Spanish team. Also a lateral view, of course, and this of the 2 wrists. These are the results of the this patient. It really didn't show many abnormalities. We will publish our results very soon in the Journal of Hand Surgery European, that for dynamic instability you need clenched fist plus ulnar deviation, not only clenched fist on the X-rays to increase the instability. But in this case there was not much seen. We have the access to the MRI scan very easily. To me, nothing very special can be remarked on the MRI scan. No bone edema. The scapholunate ligamentous complex, including the dorsal capsule, seems quite normal. There is some extension of the lunate, but no clear dorsal scaphoid translation. So I know, there are many other possibilities for supplementary examination before going to the arthroscopy. I know Lucian uses frequently the ultrasound. This is what we are currently publishing. This is a new technique. It's a bit simplified for DCT. We perform 2 CT scans, a normal unloaded CT, and then a CT with a wrist in clenched fist and ulnar deviation, and try to see if the loading increases the scapholunate distance and the dorsal scaphoid translation. CT scans have, of course, the advantage to dismiss the problem of superimpositioning of the carpal bones, especially on the lateral radiographs. After segmentations, we can then compare the 2 scans. Just as remark, the landmarks that we use are the centroid caps of the longitudinal axis of the bones through an automated manner. This was the case, this last case, the scapholunate distance, you can see it under loading. It doesn't change very much, but what you see is that the scaphoid clearly flexes and dorsally translates under loading. This is the instability case of this patient. You can compare it with a healthy volunteer. He did the same CT scans, and you see that the scaphoid flexes a little bit, but it doesn't dorsally translates. Of course, the best way to really confirm diagnosis is arthroscopy. You believe only what you see yourself. You can reveal the extent of the instability and the ligaments that are involved. You should do it in a very systematic manner. Our paper written together with Professor Matela may help you in this case. In this case, the volar extrinsics seemed quite okay. The volar SL ligament was degenerative. The DCSS was not recognizable anymore. There was a partial disinsertion of the DIC to the scaphoid. There was a clear step-off of the SL joint. And when you probed it, it was an EWAS 3C. So now we have the second poll question. What kind of treatment would you propose, knowing that the conservative first treatment failed, of course?
So we are agreeing that it's a chronic.
It's chronic, dynamic,
instability
with dysfunction.
With no static instability on the
no static
imaging.
instability. He did physiotherapy.
Okay.
It didn't work.
So how do you treat that?
I think the left of the room, they
Someone
didn't...
from
yes.
Mexico.
Yes, the left of the room, they didn't speak so much, or... Okay, or in the middle of... In Poland. You are just in front of me, I'm sorry. I'm sorry.
Dorsal capsulodesis, I think.
Which one? You are in the basic...
Round block with my Schulke.
So for Schulke,
he was on my table, yeah.
Okay, it's at your table, but why would you choose this kind of capsulodesis?
Because this is this is the chronic problem. We have maybe a lot of tissue, but not good, and only capsulodesis by Matulin will be, I think, the minimal, and we have to do more and more tissue to grab around the ligaments for the dorsal.
Thank you. So if I understand, you would choose the capsulodesis before the arthroscopic step. Yeah.
Okay. I have a question. In your pole, Schulke, you have arthroscopic capsuloligamentus plication
and dorsal
capsulodesis. Is that also arthroscopic? Is there any difference?
I think Alain made the question, but
I did the pause.
I think she meant open dorsal.
Yes,
would that be open?
I think arthroscopic capsuloligamentus plication are the dorsal reinforcement, the huge, and the dorsal capsulodesis would be the IDCLR, the arthroscopic dorsal capsuloligamentus.
That's a thin line for a lot of people.
Yes, it depends. You do a small capsulodesis or a huge capsulodesis, as we discussed this morning. I would like to come back to Manchester because I'm really wondering what would you do before doing our course, before coming here? What would you do? What do you do usually in this kind of cases in the UK?
Be careful, Zaf is watching you.
Yes, that's why we are. Monday morning it will be difficult for you.
I think it's quite variable.
Yes, you need. Sorry.
I think it's quite variable. You can do a dorsal capsulodesis. You could do it open. There's no arthritis, so you could put some anchors in and suture that to the dorsal capsule. I wouldn't have done it arthroscopic before. Now I would. The other option is you'd go to something like a 3LT.
Do you do some reconstruction? You do some reconstruction or ligamentoplasty in this kind of cases?
3LT.
You open and you have a 3LT and you have good results on the range of motion. No stiffness.
Yeah, some stiffness.
Okay, wait, who would vote for the dorsal capsulodesis if it were like a burger, open capsulodesis? Because the ADCLR is not a capsulodesis, as Christophe told us so a million times.
Everyone says capsulodesis.
I know, but I don't.
I presented dorsal capsulodesis.
Okay, but who would do a open dorsal capsulodesis?
The burger.
No. Okay.
You need to put your mic. I'm sorry.
Before arthroscopy, and the next year, 1 year before, I practice open Berger capsulodesis.
That's for yes.
And the result was good, but there was a
I will
loss
show you
of
some
penetration.
pictures. Okay. I think we can go on.
It's like everybody says, there's not only one solution, there are many options. Several treatments have been described for this kind of degrees of instability. Our upcoming scope review have examined all the existing treatments, and there's currently none is superior to the other. But the arthroscopic techniques are indeed very promising, but we still need more long-term data. That's the problem. I try to make a summary of all the reinforcement applications of the failing ligaments in this paper. And this is an overview of the dorsal, but also the volar ones. Ideally, you want, of course, to stabilize this instability to no probe passage at the end of the procedure. But if you do the arthroscopic assessment, you can do the application really tailored to the ligament that is involved. The important remark was made by Jean-Baptiste that, of course, you need the capsule well attached to the proximal row bones if you want to reinforce it. Otherwise, you should apply an anchor-based treatment supplementary. This is what we did, and I'm of course obliged to Andrea Tsey, who designed these two applications. It's the dorsal round block and the radiocarpal vol extrinsic application. You can read it. Those two papers are free to access. These are transverse extrinsic reinforcements, and what we try to do with the round block is we tighten it in transverse direction, the DIC insertion to the scaphoid towards the one to the triquetrum. And with the supplementary key feature that we create an extension lever effect on the scaphoid by pulling on all the insertion to the scaphoid. Supplementary in EWAS 3C, I like to have something on the volar side also. We do the radiocarpal vol application, just tightening the radioscaphocapitate ligament towards the long radiolunate ligament at the radiocarpal level. So in this case, it went well. The instability was well corrected and with a good acceptable range of motion after 4 months. What can you now expect as an average surgeon when using these kind of reinforcement techniques? This was my experience in 121 cases with a mean follow-up of 25 months. In about 40%, a ganglion cyst was present, which supports the theory that the cysts are sometimes correlated with pre-dynamic instabilities. Recent trauma was present in 40%. The increase of scapholunate gap can be quite moderate, underlining that X-rays are not always representative for the clinical symptoms. When dorsal scaphoid translation is present on the lateral scan, then you're already dealing with EWAS stage 3 or 4, and all included cases were, of course, chronic cases. This was my tailored treatment protocol for EWAS 2, a Maturin suture or a vol application, depending on if it was vol or dorsal. For EWAS 3, a round block with or without a vol application. And for EWAS 4, a supplementary anchor-based treatment plus the round block. The pain decrease after 4 months was 60%. It increased to 80% at 2 years. Flexion extension decrease was 35% after 4 months, but in our round block paper, the residual stiffness after 1 year was reduced to 15%. Restart of activities after less than 5 months, and the satisfaction rate was good, with almost 90% wanting to do the surgery again. Interesting to see is that EWAS 4, or a drive-through sign with the scope, is associated with less predictable and positive outcome.
Julki, can you go back 2 slides?
Yeah,
behind,
sure.
Please, there is a big mistake in your slide. One again.
One?
Yeah. You are level 5.
Yeah. I don't know. That's what you were saying. So don't measure your success on the X-rays, because at final follow-up, the X-ray will mostly not change compared to before surgery. On the other hand, the dorsal scaphoid translation can be corrected most of the time with a well-performed application. Revision surgery in this series was 3%. I mostly did a second look arthroscopy with some adhesiolysis. In our next study, we are currently investigating if such second look arthroscopy is generally able to improve outcome or not. So in conclusion, according to my modest experience, you can tailor your treatment and target a specific ligament with application. So it's not one treatment for all. In our hands, application have reproducible outcome in EWAS 2 and 3, but it's less predictable in EWAS 4. So maybe we still are investigating alternative options. And finally, the more long-term outcome will give us the best answer if it's the right way that we are aiming for or not. Thank you.
You have a last poll.
Yeah,
yes,
a last
and
poll,
we have we didn't finish, and we have the last poll for the debate. So in chronic dynamic scapholunate instability, we have a very good example of chronic scapholunate instability. What to choose? We have seen that it is an arthroscopic tailored indication, diagnostic and therapeutic. In this kind of chronic dynamic instability, which factor most influences your decision to operate? If you can take maybe, I don't know, Belen. Please, what do you think about this, just to finish the debate?
Yeah, of course, arthroscopic findings, but for that we must make a neurosurgery. So,
yes.
A neurosurgery to look for more findings. And in case of you have tissue enough to do this procedure, capsulodesis is enough. And in case of has and it was 4 or 5, reconstruction is an option. For 5, perhaps salvage procedure, but the reconstruction of a scapholunate complex must be in the last steps of IWA classification. But for the first, capsulodesis results are enough at good results.
But the question is, what is the criteria to operate on the patient?
Not to do
so, if he has no pain.
Yes.
If it's no pain, no surgery.
Yeah. So for me that would be.
And patient. Never the gap.
Okay. Sometimes you have some instability, some clink, some gap. Patient is painless. Do you operate this patient, Jan, for example?
The patient wouldn't come to see me if the patient didn't have any pain.
Sometimes they are worried. At least because someone says...
If they have worries, I don't operate them.
Okay.
I tell them what's wrong and tell them what can be the future, but without pain, I don't operate.
Okay. Or if they have, I can formulate my question differently. If they have a pain, the patient is not a heavy worker and he has or she has a pain when he does really rarely some heavy activities. Do you adapt the way of life, or do you go to surgery?
If you want me to answer, I tell the patient, you can live with this, you will die with this, will not from it. So it's a question of life quality of life.
Yes.
So the patient has to decide. I can tell them what I can offer them, but the patient decides.
Because I know, thank you, Jan. Sometimes patients are worried. I don't know what you think about this, Shulki, because they look at ChatGPT now. They have small pain, and someone told them something on the X-ray, and they come. I'm going, doctor. I will have in the long term some arthritis. I need the surgery. And you know that if you do the surgery, maybe the patient will lose some range of motion. Do you decide to tell the patient you don't have any risk of arthritis? I don't operate.
Well, there's no single paper that has demonstrated that scapholunate stabilization prevents the evolution to arthritis. I think, for me personally, because pain is multifactorial, it's difficult to understand, but the only good indication for me is dysfunction. Dysfunction in a way that they try to manage to do alternative habitats, and they still have dysfunction. Then that's a good indication for me.
Yes, we need to think about the benefits and the risks, Shulki, about all the reinforcement techniques. It can be Shulki techniques or any, because we have a lot of arthroscopic dorsal reinforcement now, applications, and we know that we lose about, in average, 19 to 20% of flexion in this kind of dorsal reinforcement. So we need to make the decision very carefully. What do you think about this, Shulki?
Yeah. It's like, I always say to the patient, it's like playing a little bit for God. The nature has made the patient in this way with this kind of laxity or instability, and you will try to change it. it's not a path of certainty.
In other terms, if you have a young patient with a cyst with a very low instability, don't do Schulke application because the patient has all the range of motion and after the patient will be stiff just for this. So we need really to be careful with the indication. We don't have at the moment a treatment algorithm, but we need to work on this.
Also bear in mind that there isn't any paper showing also that dynamic instability will evolve into static instability and arthritis. Yes. So sometimes the patient will come to say, I need the surgery now so I don't have arthritis later on, which is not true. I mean, we don't have proof. So for me, it's really the pain and the quality of life, as Jan said.
And we need to follow the patient. If it is a subacute injury, that means the patient had the trauma 3 months ago and he doesn't have a huge pain, we need to follow the patient because at 3 months it can be more or less fine with the dysfunction, but the patient can worsen in 6 months, 7 months. So one thing is to follow the patient. If the dysfunction worsens, we need, I think, to go to the surgery. Do we have any other comments? On the website, on the chat? Okay, no one did any comments.
So fine, we can conclude this, as usual, exceptional session. Thank you, Schulke. Thank you, Ali. Thank you, Eva, for the great talk. Thank you, Alfonso, but he's already gone. So we hope to see you again for the next one in a couple of months. And thank you for attending all this session. Thank you.
Thank you, everyone,
Thank you, everyone. Thank you.
For the course, for everything.